So, dear Professor, let me welcome you to Prague. I'm really happy that we are past the course. It was brilliant. Thank you for that.
Thank you.
And by the way, this is your first time in Prague, being in Prague, or?
First of all, thank you so much for the invitation. It's a real pleasure to be here. I dream about to be in Prague because I know that Prague is a beautiful city. After the interview, I will have the opportunity to go downtown and to check all the beautiful sites that you have here in Prague. That is very famous in Italy for the beauty of the city that you have.
Well, probably that's one of the reasons is that there was so many Italian architects that took part on the Prague architecture. Yeah, yeah. So enjoy it, and it's for fortune we have a
sun.
We have a sun. Yeah. So you will enjoy your time here. Yeah. As I saw, because this is not the first course that I had been to. I saw you first time in Cremona. That was then the
cadaver
course, where you also presented your lecture on the similar topic of sinus lifting. You know, when I'm listening the lectures you are giving on this topic, I noticed that you have so many more detailed views in the field. You are an experienced surgeon. The question may be one what I would begin with. During your career, the sinus lifting, did it change? How did it change? How was your first sinus lifting that you did, and how did it change your approach nowadays?
My first sinus lift was done in Como with Richard Lazzara, one of my mentors, the founder of Free Eye Implant Innovation.
Okay.
And at that time, not to be arrogant, but we were the first of doing sinus lift in Italy because it was a practice, a surgical practice, that was started in the US after the 1986 big convention on sinus lift, the first consensus of sinus lift. So it was picking up in the US, but in Italy was almost unknown. In Switzerland, it took many more years later, it was introduced. So
this was 1989. 89.
In 89. And it was mainly done with autogenous bone at those time, or with freeze demineralized bone from Miami bony banks or many bony banks but biomaterials and all the story of sinus lifts started in the mid-90s in Italy and I think all over Europe.
Okay, so how did the biomaterials change the
I mean, I was a kind of autogenous bone guy, because my mentors in Loma Linda were Phil Boyne, the inventor, with heel tattoo of the sinus lift procedure, and I was raised as an autogenous bone guy. I went to follow Bob Marks, and I was training how to do tibia graft and how to do big surgical procedure with hip harvesting, tibia graft.
So you were doing big surgeries.
And then I met Steve Wallace, that we became very good friends, and he introduced me little by little to the biomaterial world, because he was using a mixture of autogenous bone and graft material, bovine origin, shifting to all bovine. And so little by little, I saw that an evidence was coming out that even biomaterial in certain kind of indication was working in clinical as autogenous bone of the patient. And it was less invasive technique because you don't have to harvest the tibia, the chin, the ramus of the mandible. We did a lot of surgery, and I've seen in my career that the main problem was from the donor side.
The harvesting the bone.
The harvesting of the bone. And we had some complication with harvesting the hip that were quite frightening, osteomyelitis of the hip.
Oh, really?
And so I said, do we really need to have this kind of risky donor side to do this kind of surgery?
So this biomaterials allows to make the procedure much less invasive at the end.
Much less invasive, even nowadays in very challenging biological situation, no bone, or 3D major reconstruction, still in the gold standards is autogenous bone. But I mainly do that kind of reconstruction in an hospital setting, not in private practice, because the patient, let's say, support, they're willing to have not optimal post-op in the hospital, but not in our private practice. I see. In our private practice, the patient that want to have a minimal invasive procedure, no swelling, no post-op, no problems.
But this brings me to another question, because what I feel, there is a lot of young dentists who don't have that much surgical experience and probably not that much skills, that need sinus lifting procedure for their patients, but they are a bit afraid of the open sinus lifting, okay? So they are told, and the approach sometimes is, let's do it percrestal, let's do it less invasive. And the question is, what do you think? Is that a correct, adequate approach to the sinus lifting? Let's begin with the percrestal lifting, so we don't do that much big surgery. Is it? Would you recommend this approach to the beginner?
This approach, lateral approach, has been regarded as a very invasive approach. But over the years, by changing the flap design, by changing the antrostomy design, the procedure is less and less invasive. Because it's not the lifting of the sinus per se that creates the invasion of the procedure. It's the type of flap, it's the type. So by minimizing the releasing incision in the muscles, by blending perio knowledge with implant knowledge, that means going in the aesthetic zone with the same type of flap that we use in mucogingival surgery, we decrease enormously the invasion of the procedure. And it's always a matter of education. And it's a matter of indications. But you know, as I'm always saying, there is only one diagnosis and many different treatment plans. When we get to the point of which indication, the biases are tremendous. I'm telling you because for the Italian Society of Implantology, we are running a Delphi consensus. I am the principal investigator, and the Delphi consensus is a consensus among clinicians that has some scientific base. We ask different questions. We rephrase the question until we reach a consensus. And the questions that we are posing now in the new Delphi consensus is on indication. And even among experts, because we found 15 experts on the topic, international experts and 15 Italian experts. And still the debate when to use one and to use the other one, it's a matter of non-consensus.
Okay.
So,
but still you are questioning an experienced professionals. And the thing is that really that much safer or that much less invasive, that much less likely to have kind of complications that the unexperienced could not solve. You know what I mean? Is that smart to begin with the percrestal sinus lift in order, I'm not that much experienced to do the open lifting?
Let's say it's always a matter of diagnose the bone deficiency that you have. On a modern way, we do. In partially edentulous patient, when we have a wide ridge, we have no deficiency on the horizontal, no deficiency on the vertical, and you have 3-4 millimeters to start with, a combination of short implants and minimal lifting on the membrane that allows you to place an 8 millimeter long implant.
Okay.
And if you think that you just increase the double the available bone, that is a minimal invasive procedure. So over the years, even in our practice, we decrease the number of lateral approach. But I do not agree with the experts that they do everything crestal, even in totally edentulous patient with minimal quantity of bone available, 1 millimeter. There is very good friends of mine from Israel, not to mention the name, that he does everything from the crestal approach. But listen, and still in medicine, never and always that do not exist. We should have a balance according to the indication. But yes, crestal approach in partially edentulous patient, this is a trend that even among the experts could be more, let's say.
I got you. I know what you mean, and I think that we could go ahead with the topic of osteodensification.
Yes, with osteodensification, with piezosurgical approach. You know, if you check the literature, there are 42 different techniques for the crestal approach. We restricted our field to 2 major techniques, osteodensification and piezoelectrical approach, even if the Cauchy approach works, in order to select the more simpler, predictable indication according to our view. Still, the bulk of evidence is on the lateral approach, and the crestal approach is fast picking up the evidence, but definitely the crestal approach should be a new way of see the patient, mainly in partially edentulous patient, because when we have to treat bilateral case with minimal quantity of bone and to do some ridge augmentation, I think this makes no sense to do the crestal approach. It's much more cost effective to do
Open
sinus lift and the lateral approach.
Okay, okay. We could also, this comes to another question, the possibilities, the treatment options then that we have nowadays that allow us to really restore a huge, very complex bone defects that are more demanding. What is your opinion? Does it belong more to the specialized surgeons, or are you that don't do anything but the surgery, or you think this field should open to the decathlonist, to the general practitioners who do the complex treatment, including conservative prosthodontics? What do you think? Is that more interdisciplinary field based on the more specialized experts?
Regular implants that we know how to treat.
Yeah.
And on top of that, there is a problem that we face all over the world, that is periimplantitis. That is a big issue, because we know exactly how to treat teeth with periodontitis, But when we get to the point of peri-implantitis, we don't have a consensus. We don't have predictable. At the University of Michigan, where I teach with Omli Wang, that he wrote a wonderful book on peri-implantitis, is a true expert. He will be in Como in June, and he always teaches at the end of our annual course on peri-implantitis. He will teach you that the only predictable way to create bone around an infected implant is to open the flap, decontamination, bone regeneration, cover, resubmerge everything, cover the implant through a protocol that is established, but we must prevent peri-implantitis.
Again, that's where we are again.
And again, I think, and I fully agree with the term created by Omli Wang, that prosthodontitis should be the exact term. I think that we provide a lot of prosthetics, fixed prosthetics.
That's not suitable with the implants.
That can be cleaned by the patient with a lot of effort. We don't stress enough the importance of maintenance. The patients are not fully motivated by doctors to follow this kind of procedure. And we invented what we call implant protection plan. We give a protection plan like when you buy a car and you have your car serviced in the official dealer. By the official dealer, you are insured, you are protected, and all the pieces and bolts will be substituted for free. So the implant protection plan is nothing else like servicing your car.
That's interesting.
You subscribe this contract. You have to come to the office every 3 months the first year. We can scale down to 4 months. If you are very clean, the third month, every 6 months. But during the life of the implant, you will be insured, you will have a protection plan if you follow the protocol. If you don't follow the protocol, you are out of the warranty. And I've seen that this idea encounters and the patient, they like it. Because I'm buying something, but I am protected, like the iPhone. Do you want a protection plan with the iPhone? You have to pay this extra. Do you want to have a life and insurance on your car? Toyota gives you 5 years. All these kind of ideas that the patient has that has been applied to implant dentistry. I cannot finish a case and leave you alone. If I leave you alone, sooner or later, you will encounter problem. So if I see the patient every 3 months, I can see mucositis. I can treat mucositis on a predictable basis, and they will not go into peri-implantitis. And then the patient selection. Try to avoid implants in problematic patients. The ones who have no good oral hygiene, they didn't understand the importance of controlling the risk factor. Heavy smokers, 1 pack of cigarettes, 2 packs of cigarettes a day. And other patients that they have a lot of risk, multiple risk factors. If you add up all these multiple risk factors, diabetes, obesity, drugs that impair, let's say, osseointegration, smokers, and then implant dentistry could be long-term a disaster. So I think what the professional should do is patient selection, motivation of the patient, doing the procedure, but at the end of the procedure, your task is not finished. You have to motivate the patient to the maintenance of this implant. And we propose the implant protection plan at the beginning before doing anything.
There is so many things to discuss about the implant dentistry and the dentistry and in general. Professor, I know that you have your academy in Lake Como. So if the people who listen to our interview, if they want to know more from the wide field of your knowledge, tell us a little bit about your academy, please.
So we have Lake Como Institute is a private center that is Academy of Osseointegration approved by the Academy of Osseointegration. There are 3 centers, one in Italy, one in Malaysia, and one in Taiwan. And we run this master certificate. You can check on the website of the Academy of Osseointegration, and it is a complete course of 150 hours of theoretical, 20 hours of workshop. We have live surgeries, and we have 1 full year with frontal lessons, workshop, live surgery, webinars, and we follow the participant over the years. And then with a faculty member of Lake Como, we created the Academy of Craniofacial Anatomy with our French mentors, Professor Gaudy, that we know France has an history of cadaver dissection. And Rossano Gabriele, he went to Paris, he stayed 3 years, and he became an anatomist, a master degree in anatomical dissection of the maxillofacial district. So I think one of the other issue that allows you to be minimally invasive, respectful for the patient, is to follow, as you did, cadaver courses in order to be more confident when you do the surgery, that you know exactly the anatomical structure where they are. And I do fight with implant company because all the implant company that wants to organize cadaver courses, they want to use the cadaver for testing the implant. And I said, first you should learn the anatomy and then do the technique. It's always a fight again. They want to apply the technique because they want to sell. That's the main problem of sponsor education.
I got you.
Sponsor education is, at the end, these companies are, and I fully understand, non-profit company. They got to make profit. They are non-profit organization. No, they have to do a profit. They have to sell to support society, to support investment in research. But even implant company, I think they need to have an idea of the doctor. First, they should be knowledgeable in anatomy and then apply the technique. But still, young guys, even young guys, young doctors, they want to do the technique first, and then they realize that they don't know anatomy, and then they go back to the anatomical, because we have different modules, dissection, techniques. Nobody wants to do the first module. Everybody wants to do the technique.
Everybody feels like as advanced.
No, everything wants to do the technique without knowing anatomy.
Right.
Even because there is a bias. Most of the teachers are clinical doctors and not anatomists. So I can teach clinical anatomy, but I need to have an anatomical guy who needs anatomy. At the university, anatomy professor is different from the surgeon. The surgeon should do anatomy, but the one who teaches anatomy is an anatomical doctor, an anatomical professor. In dentistry, everybody is an anatomist, everybody is a surgeon. So I think we should think about this differentiation. You have to learn first anatomy,
Right.
and then apply the technique. But companies and doctors, they want to do the technique.
Professor Testori, thank you very much. It
Thank
was
you so
my
much.
pleasure meeting you here, and I hope this is not the last time you are coming to Prague to
For sure.
see
And I
us
will
and
take
share
my
your knowledge.
family, because now I'm very eager to see downtown Prague and to see the beauty of your town. Thank you so much for inviting me. It's been a real pleasure, and thank you so much for the interview.
My pleasure. Thank you very much, and
Thank
have a
you.
good time.
Thank you
in
to
Prague.
you.